you've got a tremendous number of bones in your body. Some of the bigger ones, you know, your femur is the largest bone in your body. We really do become concerned when that one is broken because it is so big. It takes a lot more force to reduce it and to maintain it in a reduced state to heal. It also is nearby some major arteries. And so when the femur breaks, especially if it displaces, it can nick the artery nearby. So that one we do worry about. As you can see, there's a kind of an inner canal of your long bones, of your bone marrow. It's very vascular. And when we talk about fat emboli syndrome, that marrow, that medullary canal is broken open and pieces of fat that normally would be in the bone marrow are allowed to drift out and embolize. We're going to talk about these injuries. Okay. I apologize. I tried in advance. Some of the pictures are rather graphic. I tried not to get the most horrifying ones, but still, it's the nature of the beast here. Okay. Difference between strain and sprain. In terms of a strain, you're talking about muscle and tendon that has been stretched, in some cases overstretched, and it has suffered some micro tears. So some of the smaller fibers of the muscle or the tendon have been overstretched, therefore they become swollen and or torn. When we talk about a sprain, we're talking about the same thing happening, but to ligaments. And it does seem to be true that it's sometimes a fracture heals quicker than a really bad sprain. Ligaments are tough to heal and sometimes need to be surgically pinned back together again. So here in this case, we're talking about the tendon that attaches the muscle to the bone. Here we're talking about ligaments. But regardless, they're overstretched, there's micro tears. In some cases, there are complete tears. If you've ever heard of an Achilles tendon rupture, the whole tendon has been separated. This is your classic ankle sprain. You trip off the curb, you trip on something, your foot turns outward, and these ligaments here become overstretched and torn. Now the degree of sprain can vary. In its worst form, you have ripped these ligaments. I think probably most of us have had this at least once in our life. The swollen ankle with the bruising and the hematoma and the severe pain. Getting into stress fractures, they are indeed are fractures. They are considered fractures, but they're usually non-displaced fractures, and there's a bunch of tiny cracks in the outer surface of the bone, especially the long bones. They're related to repetitive movement, especially vertical movement. You see it in running, you see it in baseball and basketball, you see it in dance and gymnastics. So especially the foot, the long bones, the shin bone is prone to it. And in female athletes, it may accompany a triad of things: eating disorders, amenorrhea, and a premature osteoporosis, in which the bone has become weakened from diet, from excessive use, and thus easier to break, easier to crack. Stress fractures can be painful and they can be chronic, and I've actually seen folks who had compartment syndrome problems just from chronic stress fractures. So they're not something to be laughed at. Here's your classic stress fractures, just cracks in the surface of the bone. Okay. I've never known somebody to actually break a bone and displace it from a stress fracture alone. I have known of folks who have had pathological issues with the bone, tried to run a marathon, by the time they hit mile 18, cracked their hip because they had other things going on, and running should have been the last thing that they should have been doing. Okay. Let's talk about dislocation and partial dislocation. The term for partial dislocation is called subluxation, and it's when the joint, the ball part of your joint partially comes out of the socket. I am told by folks in the ED that it's more painful to have a partial dislocation than a full dislocation. Knock on wood, I've never had to try it myself, but these can be extremely painful. And then there is full dislocation when the ball, this comes completely out of the socket. Now you have to be careful with elbow and knee dislocations because there's an artery running very close to those joints. And an awful knee dislocation that disrupts the popliteal artery may require amputation of that leg if that artery cannot be salvaged. The same occurs if there's a bad dislocation of the elbow in which the brachial artery is disrupted and they can't salvage it. Okay. In this case, this is showing you the hip joint. So partial dislocations, a subluxation. The problem with this is that it may move in and out of the joint, and when it may move back into the joint, it may entrap a nearby nerve into the joint, making it absolutely excruciating. This is an x-ray of somebody with an elbow dislocation, and you can see the complete, okay, the end of one bone has come completely out of the socket. Okay. This is a finger dislocation. Okay. My daughter did this in the living room, practicing cartwheels. I couldn't believe it, which she shouldn't have been doing anyway. Okay, but you can see completely off. And here is the accompanying look. This is her x-ray. In terms of a fracture, it's a break in the bone. There's many different categories. When we talk about an open fracture, we mean that the skin over that fracture has become disrupted. So we now have a wound over the fracture. And you can never be sure if that wound was caused by the fracture itself. In some cases, yes. But if there's any wound in the skin above the fracture, that is now considered to be an open fracture, because it's possible that at the time of injury, the bone came up, pierced the skin, and the severe muscle spasms that occur after fracture brought the bone back down under the skin. So for that reason, if there's any wound near the fracture and it occurred at the time of trauma, this is considered to be an open fracture, thus at high risk for infection. These things can get pretty graphic and pretty bloody. Okay. Closed fracture means that the fracture has occurred without breaking the skin. A simple fracture means that the bone is cracked, but the two pieces haven't been pulled apart. Cracked, but they're staying in place or close to place. Okay? And a complex usually is what we call a combination of an open fracture plus multiple pieces of fracture. Okay? I'll show you some pictures. Now, it's not just the bone that's damaged. It immediately triggers muscle spasms, very, very severe muscle spasms. It can trigger a hematoma if a nearby blood vessel's been broken. The pain can be excruciating, and depending upon where the bone is that's broken, it may go through a nearby organ. Fractures the forces. This is basically the categories. In most cases, it's a normal bone, but excess force. In some cases, it's normal force, but a weakened bone. And that would be your pathological fractures. We'll be talking about them soon. And then repetitive stress, that's your stress fracture. So in most cases, the patients fall into the first category. Some kind of excessive force has been applied to the bone. The bone is healthy, but the force is more than what the bone can accept. I think this is, there's a slide that comes after that. Initially at the scene, there's great inflammation, which brings blood to the site. There's something that's called a procallus, which is kind of like a calcified clot that surrounds the break, and then that becomes hardened, and then it forms what's called a callus, which is like a bone scar, and the callus goes from the other side of the fracture, across the fracture, to the far side of the fracture, all around. So on x-ray you can actually see this callus, and then over time, just like the scars on your skin shrink and tighten, the same thing happens to the callus. Over time, you have bone cells that will move in and reform that to minimize it. However, you will always see the callus on an x-ray. And that's how they can look at x-rays of kids they're suspecting have been hit more than once and determine that they've had some old fractures, because the callus does remain to some degree. So healing actually starts within 24 hours with moving in this inflammatory process, the hematoma, and the procallus. But healing may take up to 2 years, especially if it's a big bone like a femur. And this just shows you. Okay, so here we've got inflammation, we've got blood coming to the site. The hematoma converts to granulation. Granulation converts into like this bony calcified substance, which envelops the area of the break, and then over time, that callus is remodeled and thinned out. But can you see this lump here? That's the permanent callus that will always show up on an x-ray. Some common fraction complications. We talked about arteries being very close along the line of the femur. You break your femur, especially if you displace the femur, so the two pieces come apart. The first concern they have is, did you pierce the artery? You can actually bleed to death by bleeding into your thigh if that artery is pierced. So they're looking at how large, to what size did that affected thigh expand. Hematoma, bruising, monitoring H&H, and possibly doing some vascular studies. If you break your pelvis, you've got arteries that run in your groin area. Broken pelvic bone can break one of those arteries as well. Pelvic fracture can also perforate the bladder. It's been known to do that pretty frequently. We've talked about spinal cord injury when the vertebrae are broken. And if you break a rib, that can perforate into your pleura, creating a pneumothorax. Okay. We're going to talk about these last three towards the end of the lecture. Okay. Types of fracture, I think it's easier just to show you. Okay. Transverse, when the crack goes across, okay, the bone, so perpendicular to the length of the bone. Linear, when it follows the same line as the bone. Oblique, kind of goes on an angle. In this case, this is non-displaced because the bone's cracked, but the bones are still in contact, bone fragments are still in contact with each other. Here you have oblique displaced, so the bone fragments have been pulled apart. This is a spiral. It takes a lot of force to do this. You may see it in sports and with the children. The bone is actually twisted, so it's broken and rotated at the same time. Green stick fracture is what you see in the kids sometimes, especially of their forearms. The bone, the bone breaks. It's like the branch of a living tree. You can bend it, and it will break on top, but it won't break on the bottom. So basically, the arm or the limb has been bent, and the outer shape of the bent bone cracks, but the inner shape, the inner curve does not. That is typical of a bone that's still growing. Okay, so are young kids on the playground. Comminuted means it's been shattered. Multiple fragments. In this case, this bone that they present here is your femur. This gives you an example of a non-displaced ankle fracture. Can you see the crack here? So the bone has been broken, but the fragments are still in contact with each other. So there's no need to reduce this fracture. They'll just cast it or splint it. Here you have a displaced fracture. See, this bone has moved apart from here. I know. I tried to use x-rays as much as I could. These two bones should be in contact with each other. So they have broken both the fibula and the tibia of the lower leg. Okay? And there. Okay? That's an open displaced fracture. Okay? Comminuted here, shattered. Do you see all those fragments down there? And all here. So when we talk about somebody shattering their ankle, or shattering their forearm. That's what it looks like on X-ray. In terms of multiple trauma is somebody who presents to the ED with more than one injury, all of them extremely serious. In almost every case, a multiple trauma is brought to the emergency room. There's some kind of orthopedic injury. It may be in addition to internal bleeding from a ruptured spleen and a head injury or burns, but usually orthopedic injuries are often involved. When you look at the statistics for multiple trauma patients, they are almost always young and male. There's some type of risky activity or hazardous activity. There's some kind of height or velocity involved. Speeding car, jumping from a certain height. Motor vehicle accidents with high speed, especially distraction accidents. They're on the phone, they're talking with their buddies, they're trying to eat it while drive. Disregard for seat belts, for speed limits, for lane changing, and so forth. And substance abuse, be it alcohol, be it marijuana, be it something else. Pathological fractures are those fractures that the bone has already been weakened by disease, and therefore it's just like glass, and it doesn't take much force to break it or to shatter it. And the diseases that cause pathological fractures, osteoporosis is one, cancer is another, malnutrition is another, and osteomyelitis, which is infection of the bone, in which there's actual bone loss. So it doesn't take much to break a bone that's already weakened. And one of the common ones are the elderly postmenopausal ladies who take a fall from standing height onto an outreached hand and break their wrists. They're not falling from a great height, and they're probably not falling at a high speed, but they have osteoporosis, particularly of the wrists, and that's all it takes to break both bones. Another one is seen in the oncology world, and that's either with primary bone cancer or bone metastasis, and the bone breaks. Elizabeth Edwards, for example, the wife of former Senator Edwards, had metastatic breast cancer to her bone. She coughed and she broke 3 ribs. I've seen a patient with osteosarcoma so bad that when we stood him up to assist him to a chair, the weight of his body broke his femur. So it doesn't take much. Also, long-term steroid use. Steroids aren't kind on the body. It's a helpful drug when you need it, or helpful drug category, but they are mean to bone, especially the top of your femur. They cause something called avascular necrosis, in which steroids kind of attack the top of your femur bone, where it attaches to your hip joint, reduces perfusion, and lets the bone kind of just die off and crumble. So you may have patients, elderly patients or patients on steroids, brought in through the ED with what's called the hip fracture due to avascular necrosis. This is a pathological fracture that's the result of bone cancer. In this case, this is sarcoma. And you see how the top of this femur just came right off the femur. And you can see the porous nature of the bone. Okay, you should be seeing strong white bone here, and you're not, because the disease has pretty much taken a bunch of it away. Now, the symptoms of fracture are going to depend upon the location. It's going to depend upon the extreme of the severity of the fracture. Usually there's pain, there's tenderness, there's swelling, there's some kind of limited mobility, even if it's guarding that area or taking some of the weight bearing off that area. Deformity you'll only see, other than the swelling, you'll only see deformity if there's a displaced fracture, outside of the inflammation. You're probably going to see some bruising, you may see some hematoma. Depending upon the severity of the break and where it is, you may see muscle spasms that are so strong at times that if the bone was broken through but not displaced, the resultant muscle spasms alone can be enough to pull the 2 pieces of bone apart, especially with the broken femur. And then we talked about the wound. Because there's that risk that the bone did pop through the skin, but get pulled back down under the skin by the muscle spasms, we treat any wound near a fracture as if it was an open fracture. In terms of fracture care, immobilize from above to below the fracture. Immediately cover any open area with a sterile piece of dressing. And then they need to bring the bone pieces back into alignment. That's called reduction of the fracture. You do the same for dislocation. You have to reduce the dislocation. And that needs to be done under drugs. I'm sorry. Ideally, conscious sedation. The same sorts of things we would use for topical burn care. A little bit of Versed to relax them and give them amnesia, a little bit of fentanyl or a little bit of propofol, and then you reduce the fracture. You guys ever seen a fracture reduced in the ED? It's actually kind of wild. These orthopedic guys just grab one end, and I've actually seen one of them put his foot in somebody's armpit in order to reduce the humerus, and then they just tug on things and snaps it back into play. If they can't do it easily, manually in the ED, the patient goes down to the OR and has it done in the OR. But it should never be done without some kind of pre-medication for a patient. ORIF refers to open reduction, internal fixation. That's when this cannot be reduced in the emergency room manually, even with conscious sedation. There may be too many pieces, or the displacement may be so great, or they're afraid that in reducing it, they're going to trap a blood vessel or a nerve. So they make an incision nearby the fracture, they visualize down to the bones, and they start putting things back together with plates, with screws, with wires. So they reduce the fracture directly, and then they fixate everything in place with some hardware, sew the patient up, and that's called the ORIS procedure. In terms of taking care of a fracture patient up on the ward, once the fracture has been reduced, it's a matter of comfort, so narcotics, maybe some muscle relaxants for the spasms, some ice for the swelling, and then it depends if the patient's been splinted, casted, or put into traction. If there's any kind of a wound near the fracture, and that's a new wound, they're going to treat it as an open fracture, so that's antibiotics and a tetanus shot, regardless of when their last tetanus shot was done. And then depending upon the fracture location and severity, physical therapy and rehab. Okay. Now in terms of how they can cast people, there's two kinds. There's the old-fashioned plaster of Paris cast. There's the synthetic fiberglass cast. There's also these pre-made splints that in some cases work very well. Plaster casts is something the military still does because it's cheap. The trouble is it takes forever to dry. It's a mess to do. They basically dip rolled Curlex like stockinette in plaster and then kind of roll it around. But the first thing they do is they pad. They take cotton, not cotton balls, but like cotton batting, and they pad every bony prominence, and you want a layer of padding between the actual cast and the skin, but especially not around bony prominences, like the bones around your wrist, the bones of your elbow. Those get extra padding. And then on top of that, they wrap this very wet rolled Curlex. And they do several layers. And when it's been done with plaster, it's going to take time to dry. Until it's dry, it's called a green cast. Green cast means that it's a wet plaster cast, and it may take 48 hours to dry. Depends upon the size of the cast. So while it's drying, you don't want to touch this wet cast, because if you came up and tried to lift their leg up and it was a green cast, you would cause an indentation in the cast and actually push it in against the patient's skin. So when you're dealing with a green cast, it goes on top of, you elevate it, put a chucks onto the pillow, and you put your hands under the chucks or under the pillow, but never directly on the cast. Okay? Plaster casts are heavy. They kind of stink after a while. They kind of erode. They start peeling and crumbling away. And if it gets wet at all, it seems to melt. So these are the ones they can't go in the shower or the pool with. You've got to put a trash bag around them and have them stick their arm out of the shower. They're cheap, but they take forever to dry, and they just don't hold up to time, especially with the kids. The fiberglass casts or the synthetic casts are a bit more expensive, but they have so many other advantages. They dry quickly, they're not as heavy, they're more durable with the kids. They don't fall apart when they get wet, they don't crack. So whenever possible, we try to do the synthetic fiberglass. And these days, the kids can actually pick their own colors out. It's kind of cool. Or there's some that come in patents as well. Regardless of the cast, you need to be able to get 2 fingers between the skin and the cast at either end of the cast. If you can't get 2 fingers between the cast and the skin, then the area is too swollen, and they really should do something called bivalve. You know what bivalve? Have you heard the term bivalve? It's when they cut the cast in half, a top half and a bottom half, and then they use ACE wrap around it to keep it together. But the benefit of that is if there is swelling, the casts can kind of move apart a little bit while still keeping that limb in alignment. So if you can't get 2 fingers between the skin and the cast, they really need to come and bivalve it. Okay. The other thing that you need to do, especially with the plaster cast, is what's called pedal tip the cast. And that's when the plaster cast can get quite sharp when they dry. And so if I have a cast down to my wrist and I move my hand, I'm going to cut myself here. So you take pieces of adhesive tape, the real thick white stuff, and you take 2-inch strips. And if this is the end of the cast, I'm going to tuck 1 piece of tape here, I'm going to bring it out, and I'm going to bring it over the sharp edge. So you're basically putting tape around the sharp edge, from the inside to the outside, covering this sharp edge. So that's called peddling the cast. Okay. Whenever there's a cast, regardless of plaster or synthetic, this is what you need to look for. If that injured limb is extremely swollen, they will either bivalve it or they will delay until the swelling comes down. The biggest concern is that you can't see the area of injury because of the cast. And if there's swelling occurring, you can't see the swelling until it's almost too late. So these are the symptoms that somebody's limb is in trouble with the cast on. Is that 2 Percocet might have worked 2 hours ago, but now 2 Percocet don't work. So the pain is getting worse, and it's unrelieved using meds that used to work. And that's telling you that the swelling is increasing, but the cast is too tight. If the fingers start swelling up, even though you've got this casted arm up on 2 pillows, and you've got ice and bags on top of the cast, the fingers are swelling up, then you can imagine how swollen the arm is inside that cast. If they say there's a burning spot, so if they've got a cast over their arm and they say, it burns by my elbow, that might mean that some of the plaster has been pushed in towards the skin, has moved, kind of pushed away the cotton batting, and you actually have sharp cast material rubbing against the skin, causing a bit of a pressure wound. So we call those hot spots. So they're saying, the break is here, but the pain is here and it's burning. So that means the cast is rubbing against the skin. If the cast starts coming apart, or you have irritation, the peddling wasn't enough. If the cast starts to stink, not just regular body odor, but purulent, then you worry about, was there a wound in there to start, or is there a pressure ulcer now in there because the cast started to rub against the skin. And now you've got some kind of a purulent pressure point down there. And then the 6 Ps, and the 6 Ps are always on NCLEX. Okay? And imagine a cast on an arm. So if the fingertips become pale, if you can't detect a pulse, if they can't move their fingers, or they can't feel their fingers, it's just tingling and numbness. Or pylothermia is cold, the fingers feel cold. Those are the 6 Ps. And if it's an upper limb cast, you look at the fingers. If it's a lower limb cast, you look at the toes. Now, it may not be that easy to get a pulse depending upon the cast. In some cases, the cast may leave the wrist area free, or it may leave the top of the foot free. So, but getting a pulse will depend upon the type of the cast that they use. So go with capillary refill, slow capillary refill if you can't get the pulse. The removal is a little bit scary. Remember, they're medicated for the application usually, but they're not medicated for the removal. And it's scary because they bring out this saw and they plug this thing in and then they come towards you with what looks like a saw. But it's not going to hurt them. It stops the minute it breaks through the top of the cast. It's an oscillator, okay? And it works by more vibration. It doesn't work in a circular manner or goes down deep. It kind of goes like this, okay? Once you get the cast off, it's sometimes a little surprising to see a limb that's been casted for many weeks. There'll be muscle atrophy. The skin will look kind of brown. It will be kind of smelly. And you'll have looks like a wax almost on top. And that's the sebaceous glands, the oil from the sebaceous glands that rose to the skin but had no place else to go. So they need just a good washing, a good face cloth. It may be a little bit sensitive, so you don't want to be scrubbing at them too much. But a wet face cloth with some soap usually takes care of it. This is removing a cast. Okay? They'll use this saw first, and it functions by vibration, but it makes a lot of noise. They break through the outer hard shell, and then they combine with these, like retractors almost, and they pop the pieces of the cast apart, and then they use the bandage scissors to cut through the padding that's underneath the cast. In terms of traction, there's 2 types of traction we're going to talk about skeletal traction, and we'll talk about skin traction. Traction just means I'm going to be yanking on this broken bone with an attempt to try to get the pieces back in touch with each other and hold them there so that they can knit. The traction force is the force you're going to pull on the foot. For example, if they have a broken femur, the force you apply to the foot to pull it away from the body of the patient is called traction. But if you didn't have countertraction and you yanked at a patient's foot, you'd just be pulling him down to the end of the bed. So you need countertraction to hold the patient down while you're yanking at this foot. Countertraction you use by the positioning of the patient, the weight of the patient, and in some cases some weights that hang off the device. And let's just go directly here. This is skin traction. Okay? Very common. An elderly person falls, breaks their hip, comes in the afternoon, is prepped for surgery the next morning, but in the meantime, we're going to put them in buck skin traction or Russell's. It's pretty much the same thing. To try to pull on that fractured leg, kind of see if we can align it, reduce it a little bit, and in doing that, we'll reduce some of the spasms. So there's usually a special kind of a boot that you put on the foot. It velcros cross. It has these bars on either side. This gets attached to ropes. This is all part of an orthopedic frame on a bed. So we've tied rope. The bottom of this foam booty has a bar on it. You tie rope to the bar, and then you bring it past the pulley, and then usually for an average size adult, you put 5 pounds of weight at the bottom. So you're doing constant 5 pounds of traction, bringing the foot in a distal manner. On a large individual, you may have 10 to 12 pounds of traction down here. This is only temporary. This is to get them until they can be managed in the OR with an ORIF. And it's primarily done just for hip fracture. Okay? So I'm not putting anything into the bone. I'm just wrapping something around the patient's skin and tugging on that. Okay? So this is called skin traction. And there's only one form, one direction of force, and that's towards the foot. We're hoping that the patient's weight will hold the torso in place as this 5-pound weight yanks on the foot. So this is basically simple skin. This is a bit more complicated. We'll come back to the narrative slides in a minute. This is balance suspension skeletal traction. And in most cases, this is used for a broken femur. It can be applied in the OR, or it can be applied at the bedside under some conscious sedation. So say here's the break up here. The thing about the femur, it's such a large bone, it takes tremendous force to realign those fragments and get them back in contact with each other. So you're going to have to apply direct force to the bone. So they go right through the fibula, right below your knee, and they pass a pin or a nail or some kind of a bar through that bone. So it's exiting here and it's exiting on the other side of the knee. And then they apply this weight directly to that bone. And in doing so, we're yanking the lower part of the fracture, stretching it out, and hopefully popping these two pieces back in place. Now, the amount of weight you have to use could bring this patient down to the foot of the bed if you didn't do counter traction. So on here, do you see part of the bar involves this thing here, this frame here? This comes up here, and these weights are being applied to this bar in the opposite direction as the weight that's being applied to the foot at the foot of the bed. Does that make sense? So this weight is pulling at the foot end, and this weight is keeping this patient in place so that this traction here can try to bring that distal fragment out and back in alignment. Okay. And this is your full orthopedic frame here with a trapeze so that they can move themselves around. The nice thing with this is called a Pearson attachment. So the leg is lifted off the bed. This is called the Thomas splint here. The counter traction is called the Thomas splint. So this patient can move around in the bed with the overhead trapeze because it's the Thomas splint that's in charge of the counter traction. So just remember, broken femur requires a tremendous amount of weight at the foot of the bed, that the weight is applied directly to the bone, to the fibula below the knee, and that as counter traction, you're using the Thomas splint, the weight and position of the torso, and the weights that are being pulled in the opposite direction. Okay? They can be in this thing for 6 weeks. My brother spent a whole summer in this thing. Fell out of a tree the day after school ended. Okay. The important thing here is issues with immobility, constipation, atelectasis, decubiti. You're also concerned about the wounds here, the pin care, because these bones, this pin here is going directly through that bone. So you have 2 wounds and a piece of metal that goes from outside the skin through the bone. So great risk for bone infection right here. Okay. Let's go back. Okay, so traction force and skin traction. Applied indirectly to the bone using usually this foam booty. Okay, it's usually done pre-op for hip fracture surgery. And the amount of traction varies, but in the average elderly patient, we use about 5 pounds, and it can be put on at the bedside. And usually once you get this in place, the patient is much more comfortable, because by tugging on that distal aspect of the fracture, you're starting to reduce it, and that alone stops the muscle spasms. So once you get them in this, they're not terribly comfortable, but they're more comfortable. Okay. Now the skeletal traction, we're applying the force directly to the bone using some kind of orthopedic hardware that grabs onto that bone. These are just some of the terms. Okay, a Steinman pin is what I'm used to working with, and that is it's just screwed in under local anesthesia at the bedside. Kirschner wires are usually for smaller bones. Tongs are for cervical tongs with the neck fracture. But with the femur fracture, this is what you're using. Okay. The amount of traction weight will depend upon how badly the fracture is displaced, the size of the patient, but for the average adult, you're looking at 30 to 40 pounds. Okay. You can use this pre-op, or you can use this as the major treatment. It can be put on at the bedside or in the operating room. If it's used for more than 24 hours, then you've got concerns of immobility. And here, okay, this is a Steinman pin. Okay, this is it before application. It's got one sharp end to it. They kind of attach one of those kind of screwdrivers, though I have also seen them use an electric device. This is done under local. I also like to see it done with a little bit of sedation because it can be kind of scary. And this thing is drilled from one side to the other. The pin exits out of both sides, and then you put a cap on the sharp side so that you don't injure yourself. And then around the pin goes this device here, and then the weights go here. The traction force is tied on here. Okay. So you've got two wounds here with direct access into the bone. It's a high risk of bone infection or osteomyelitis. Okay. Okay, I think we've done that. The guidelines. And biggest start here, because this is always on NCLEX, that when you're using skeletal traction, you want the ropes to be free-flowing, not caught up on anything. Okay. You don't want the patient hanging something off the ropes, for example. Okay. The weights, the pulleys, all need to be free-flowing and unobstructed. Okay. You got to check the ropes because with time they can be frayed. So if you start to see fraying of the ropes, they need to be replaced. We talked about covering the sharp end of the pin. That is considered to be a contaminated sharp. You may hurt yourself on it if you're doing care of the patient. You want the patient always in alignment. Once the feet of the patient touch the foot of the bed, the force of traction stops. Okay, so have to have them up in the middle of the bed. They need the overhead trapeze to move, and then you try to minimize the risk of immobility. So stool softener, DVT prophylaxis if need be, and incentive spirometer. And then meticulous pin care. In terms of the pin care, there's been a lot of research about what's the best thing to use. Unfortunately, there isn't any consensus. You'll see all sorts of things, but the biggest consensus, the biggest principles they do seem to agree on is that the pin site needs to be cleaned, crusts need to be removed, and that you need to check the pin site for inflammation, for purulence, and if you see that pin site that wound around the pin start to enlarge. Okay. So there's a bigger gap around the pin than what there used to be. That those things are reportable. Most folks use a combination of sterile water or saline with sterile Q-tips to clean the pin site. Depending upon the orthopedic guy or lady, they may ask you to put antibiotic on the pin site as well once a shift, but that's surgeon preference. Okay. Do avoid betadine and peroxide because that will erode metal. Now we have other types of traction, but they don't involve weights and pulleys, and they are called external fixators. You may hear the term Hoffman, a Hoffman fixator. So this is done in the OR, this isn't done at the bedside. But it's a matter of, in the OR, putting the bones together and then keeping them in place with this frame. Now this frame goes into the bone directly. So you have a number of pin sites. Why would we do this? Usually we do this sort of thing if there's been extensive trauma to the limb, there's wounds, there's incredible swelling, there may be some skin grafting that needs to be done, and we don't want to hide those things. We want everything to be out in the open. Okay. That's when we would use a Hoffman fixator instead of putting somebody in a cast. These things can be pretty large. In this case, this is just of the lower leg, which is a common one. Okay. There's one that can be put onto the pelvis. Okay. This is different. This is not a Hoffman fixator. This is an Elizarov, which is used when you want to grow bone. Okay, this was designed by a Russian orthopedic surgeon, which was named after him. It's used for limb reconstruction when there are bone gaps. They have also used this in pediatrics when they're dealing with patients of very short stature, like dwarfism, and they want to extend the length of the limb. So they actually break the bone, they put this on, and over time, you know, if these are the two pieces of bone, they intentionally broke them, you're going to have some bone growth between them. So over time, with the bone growth, you keep bringing these things apart and stretching that, and that's how they can use the Elizarov to gain some limb length. But if there's been surgery that's resulted in bone loss, you know, a shattered, you know, a terribly shattered ankle, for example, they may try to use this so that we're using the natural healing process, but over time moving pieces of this frame apart to fill in that graft. So over time, this moves. So you can actually move these things outward in either direction to grow bone in some gaps. Actually, this doesn't grow the bone, this stretches the new bone. Okay? And this is called the Elizarov. The concerns are the same as the fixator. You've got pin sites that need to be looked at to make sure there is an infection as well. Fat emboli?
Did they use that for kids at all? You know, some kids are ones like bigger than the other.
Yeah, that's what they use. It started off with the children.
And it's safe for that? If the bone's still growing and everything?
Yeah, yeah. It started off with use for children. Yeah. Fat emboli happen. This isn't a clot. This isn't an air emboli, but it's a piece of fat that breaks off of the bone marrow when an open bone has been broken and displaced, exposing the marrow. Okay? And so you've got these little pieces of fat that the marrow is very vascular, that come off, enter into the bloodstream, and then move in the bloodstream until they're lodged, resulting in some kind of a respiratory event. And this is called a fat emboli. It usually happens when there's been a break in a long bone, but it can also happen with a total joint replacement, especially knee and hip, where they saw off one end of the bone in order to get the prosthetic in there. In terms of trauma, if you can quickly reduce the fracture and hydrate the patient, you can reduce the risk. I have seen this a couple times. All of a sudden, the patient, maybe 24 hours after the injury, suddenly becomes confused and a little short of breath. We move them into the ICU, we watch them, we give oxygen, we hydrate them, and then we usually wait it out. I've never seen it to the point that a ventilator needs to be used. It's always responded to IV fluids and oxygen. But remember, it's not just an open fraction, it can also happen with the joint replacements. You guys heard of compartment syndrome? Okay. Always on NCLEX. Remember, your muscles are not just one compartment. There's clusters of muscles that then form your calf, form your thigh. Okay? And there's a sheath around the cluster of muscles. That's called your fascia. Okay? So inside your fascia, you've got all these clusters of things. There's a covering on each muscle, but there's the bigger covering is over the cluster of muscles. Within each cluster of muscles, you have veins, arteries, and nerves. So if a piece of muscle has become so injured, it's terribly edematous. And the pressure's going to go out towards the skin. But if the skin can't stretch anymore, then the pressure U-turns it and starts going in, similar to herniation, brainstem herniation. But in this case, what you have in the middle of the nerves and the blood vessels, and they get compressed with severe compartment syndrome. Okay. You see this a lot with crush injuries of the lower extremities, or a really, really bad shattered fracture. You can also see it of the arm, especially the forearm. Okay. I've got this here, so it's severe and uncompensated edema, badly shattered fracture, crush injury. We also see it in electrical burns. Okay, I think we've talked about this. Indications: severe pain despite medication that used to work, and especially on passive movement. If you have them dorsiflex their foot, or have them kind of bend their wrist like that, and the pain gets worse. Any kind of movement that's going to make that muscle work. You challenge the muscle, and if it's too swollen, there's compartment syndrome. When you challenge that muscle with movement, there's going to be incredible pain. There's going to be swelling. You're going to notice that. First thing you do is you elevate the limb, you get ice on it, you call the physician, and then they do something this. Okay, this is called an intercompartmental pressure monitor. You can do it intermittently up here using a needle. You just perforate, you cleanse the skin, perforate, and you should be wearing gloves. Perforate the skin, go into the muscle cluster itself, into the base of the muscle, and you'll get a pressure readout here. This can also be done continuously if you think somebody's at risk, and so the needle is put into the muscle, a little catheter is put in, catheter over a needle, and then the meter is kept in place. Okay. If the meter shows pressure of more than 25, closer to 30, then that muscle is in danger of becoming necrotic because of lack of perfusion. And you're in danger of having nerve damage as well. So what they need to do is something called a fasciotomy. This is done in emergency. It can be done at the bedside. We used to do it in the tank room on the burn unit, but it can also be done in the OR. Okay. In which you have to, under sterile conditions, cut through the skin, cut through the subcutaneous fat, and cut that fascia that's over the muscle, release the pressure so that the muscle, the inflamed muscle, can move outward and off the blood vessels and the nerves. Okay. And this is just an example. When you do that, the minute you open the fascia, if the muscle is terribly swollen, it just pops up. It's kind of freaky. Okay. You leave this wound open, and then when all the danger has gone, plastic surgery closes this wound. If they can't get the sides of the wound to reapproximate, then they put a skin graft. A little bit about, yes? Mm-hmm. Okay. A little bit about hip fractures, since it tends to be on NCLEX, you tend to see it a lot. It is the most common fracture among adults. It usually occurs from a standing height, and especially among our elderly or postmenopausal ladies. And that's because at that point in life, your bone is starting to become a little weaker, a little thinner. You've got some osteoporosis going on. The classic signs of a broken hip, other than extreme pain, is that one leg looks shorter than the other, and the shorter leg is rotated internally. The toes are rotated in. So whenever you have somebody, you find an elderly person on the floor, they're complaining of acute pain, you see one leg shorter than the other, and that shorter leg internally rotated, the concern is hip fracture. Okay. They're brought to the hospital, they're put in skin traction, and then they're taken down to the OR. If they can reduce them and pin it together, they will. If they can't pin it together, then they replace the whole hip joint. THR is total hip replacement. And what they do is they literally saw off the top of your femur, and they ram this prosthetic device down there, and then they replace the socket. So there's two pieces to this prosthetic. One is the capsule part of your joint, The other is the ball part of your joint that goes into the capsule. These people come back and they hurt for a good reason. Because in order to do this, they first have to manually dislocate the hip. Then they saw the top of the femur off, and then they ram this thing down into the canal of the femur. So it's no wonder that they come back in quite a bit of pain. Unfortunately, there has to be some pretty stringent activity and position limitations because these things don't last forever. In some cases, they loosen, they come apart, and so your best bet to keeping it in place is to do what you need to do in terms of position and limitation. Okay? General post-op care, they tend to become anemic post-op. They usually have a large estimated blood loss because this is major orthopedic surgery and it's kind of bloody. If they can, they donate their own blood pre-op, and that is administered back to them intra-op or post-op. If they have not, then you really need to check their H&H post-op. It's not unknown for them to require a unit or two of packed cells. Because it is bloody surgery, they come back with a drain in place and usually a hemovac because the drainage is more than what a Jackson Pratt can allow for. Foley, this is long surgery, and they're going to be in bed for a little bit. So Foley to gravity, pain management, DVT prophylaxis, and then they're usually, depending upon the type of prosthetic, there's two kinds of hip joints that they put in. One is cemented, and the nice thing about a cemented joint is that it seals in place immediately, but in terms of the OR staff, it's an extremely toxic process because of the fumes that the cement uses. So it's more burdensome on the OR staff than on the patient to do a cemented joint. The nice thing about a cemented joint is they can get right up and walk on it post-op. The other alternative is something called a porous joint, and it has little holes into it, and the bone grows into the holes over time and seals it in place that way. These folks cannot walk on that leg for several weeks. So it's real important to know what type of joint have they put in, the cemented or the porous. You heard about the abductor pillow? Okay. Because they have dislocated this hip and they've injured the muscles, then they've cut through the muscles. You can't count on the muscles to keep the ball in the socket on a hip joint for some months. So to do that, to keep the ball of the hip joint in the socket, you have to keep that leg abducted at all times. And so you use the abductor pillow to put space between the feet, and that keeps that hip joint in place. They need to have this pillow in place whenever in bed. They go home with it, they use it at night. Anywhere they go, they need to keep their feet apart. If they're sitting in a chair, they stand up the abductor pillow and they put it between their knees. If they're on their side, they use this, you turn it around and put it between the knees, okay? Other limitations, and star this because this always shows up. You don't want that leg crossing over the midline because when it will pop the joint out. You don't want them sitting more than an hour, and you don't want them sitting in a chair that's nothing but 90 degrees. Okay, if it's a deep chair, it will bring that hip joint less than 90 degrees and it will pop the ball out of the socket. So a 90-degree chair would be, one of these blue ones, or like a dining room chair, a real sturdy, not a soft couch, okay, something sturdy. You don't want them rotating their leg inward or outward, and you don't want them bending low at the waist. They need an elevated toilet seat for the same reason. You don't want to bend that hip more than 90 degrees. And no quick stop, start, or repetitive motion on that foot. And then finally, a little bit about digit and limb replantation. This is pretty cool stuff. I was working at Mass General in '81 when Dr. Malt did the first replantation, and he sewed somebody's hand back on at the General. It was pretty amazing. Since then, this has pretty much become standard. You see this at almost every university hospital, every tertiary facility. I know the Fairfax does it. I don't think of Nova Alexandria or Mount Vernon, but Fairfax certainly. It is incredibly labor-intensive surgery, and it is done at a microvascular level, using a team of plastic surgeons and orthopedic surgeons, and sometimes neurosurgeons if nerves are involved. Easy if it's one finger that came off, that's easier than putting somebody's arm back on. Now in the burn unit at UVA where Professor Taylor and I worked, the same team that took care of burns also put the limbs and the fingers back on. And if we had room in the burn unit, they like to have the patients up there because they were already up there. It is incredibly labor intensive. It's kind of anxiety provoking because you're not quite sure whether it's going to take for a few days. You may need more surgeries. The big thing to know is the nerve is not going to immediately be felt. It takes up to 18 months for a nerve to heal once it's been severed. It takes a little bit longer also for the arteries. The first thing that's going to connect back will be the veins. But the problem is if the veins bring the blood to the fingers, but the arteries haven't fully connected yet, then the arteries can't bring the blood away from the fingers, so you tend to have venous congestion of the fingers or the toes. And if you let that venous congestion persist, it will be like a compartment syndrome. You want everything warm and vasodilating. So the room would be at 80 degrees, would have the warming lights up. The patient would be under a blanket. You want maximum vasodilation if you can. Sorry, this should say SaO2 probe. Okay? We used to take the pulse oximetry probe and put it on the finger. And if we got a good wave, then we were pretty sure we had good perfusion to that finger. They were put on anticoagulation, and yes, we used to use leeches. Okay, I'll show you that in a minute. Antibiotics, obviously. Tetanus shot, obviously. I have seen fingers get put back on. I've seen a hand. I've seen arms. I've seen feet. I've seen a scalp. It's pretty wild stuff when it works. Okay. Fingers they can pretty much put back on with good function. Okay. This is a hand replantation. Okay. You can see the suture line here. This hand looks great. You don't usually see it looking this good. This has been in place for a while. Okay. Initially it wouldn't look like this. These are just some orthopedic wires that are keeping some broken bones in place. And they've just capped them so that they won't be too sharp. Okay. Here are two fingers. And these are wires just keeping, or pins keeping the bones in place. Suture lines are here and over there. Okay. This is a picture of actual leeches used for venous congestion. It's hard to see, but this is a hand and this is a thumb. Whenever a hand's been involved, the thing that you want most on that hand is the thumb. Because with the thumb you can do opposition and you can grip something. A hand without a thumb is almost useless. So you want to save the thumb whenever possible. If the thumb cannot be saved, then what they can do is take the big toe off your foot and move it up, and that becomes your new thumb. That's another surgery, okay? But here, we've got serious venocongestion here that if we don't relieve, then we'll lose the finger. So you use sterile surgical leeches. And they're a little wild to see when you first see them. They're shipped in. They're in a clear container. And they're moving all over the place. And what you have to do is attract them. So you use like a lancet to prick the skin. And you put a drop of glucose water or D5W on here. And then you bring the head of the leech on and it attaches pretty quickly. If the leech does not attach, that tells you there's some necrosis going on, and when a leech won't attach to a replanted limb or a replanted digit, that's a poor prognostic indicator. Okay. So once it attaches, it's going to pull away very quickly a large amount of venous blood, thus taking the pressure off, okay, and preventing like a little compartment syndrome. Okay. Once you use a leech, you can't use it again. So we put it in a bucket of alcohol. Okay. And because of the bacteria that's in a leech's mouth, these patients have to be on, even though these are surgical sterile leeches, they have to be on a certain antibiotic. Was it freaky for patients to see these things? Yeah, it was freaky, but then they got to think, my God, if this little thing is going to save my hand or my fingers, so be it. And after a while, they used to name them and race them and all sorts of things. But I have seen the leeches actually save fingers and hands. Something to think about. Okay. A little bit about osteomyelitis. I'm going to let you read about that. It's bone infection, very, very difficult to eradicate. When you have bacteria and pus inside a bone, it will destroy the surrounding bone. You'll see pockets, empty pockets on x-ray. A lot easier to prevent this. Once somebody does have osteomyelitis and it cannot be relieved, you may be looking at an amputation. These are the folks that are on home antibiotics for 6 to 8 weeks through a PICC line, using very, very strong drugs, getting labs drawn for peak and trough of the antibiotics. A lot easier to prevent than to, okay? And then geriatric implications. I'll send out some NCLEX questions probably tonight or early in the morning. When the elderly fall, they take the hit hard. The bones break quicker, they're slow to mend. Okay? And then I'll send that out. And now we get to do course evals. Okay, so I'm going to pass out the clinical group course evals first. What I'm going to need is for you guys to be in your groups. Here we have. First, why don't you take one for the course?